Welcome to the fourth session of the scientific working group of the EHA on immunotherapy. And I welcome you all, and it is a pleasure to share today this session in which we have invited three speakers. And actually I'm the chair and I'm from Amsterdam, and I'm a hematologist and a physician scientist, and mainly focus on immunology and immunotherapy. And it's my pleasure to introduce you to Paul Bröckelmann. He is mainly working on checkpoint inhibitors nowadays. He's a resident physician at the Department of Internal Medicine at the University of Cologne. And he studied all over the world, not only in Germany, but also in Turkey, Brighton, and Buenos Aires in Argentina. So there's a lot of experience worldwide. And his main focus is on checkpoint inhibition and mainly in lymphoid diseases. So we are very happy that he is able to join us tonight and give his key presentation on checkpoint inhibition. Paul, the floor is yours.
Yeah, thank you very much for this kind introduction. You should be able to see my screen now, and I will just get into it. And I'm very thankful to the organizers for inviting me to give this talk on checkpoint inhibition in malignant hematologic malignancies, summarizing approved and emerging indications. So these are my disclosures. And I want to direct your attention also to the two excellent talks by Peter Brossart on the mechanisms of action and also mechanisms of immune evasion and relapse after allotransplant by Vago, which are to be found on the EHA platform. I divided my talk into two parts and will initially summarize the currently approved indications and then provide a perspective on emerging indications. So, as you all are aware, the checkpoint inhibitors are revolutionizing oncology at the moment, and this is especially true for the solid tumors. And this is just summarizing how many indications are currently approved. And as you can see, there are some hematologic diseases as well, and this is true for nivolumab and pembrolizumab, and I will get into more detail. Nivolumab is a humanized IgG4 anti-PD-1 antibody, and it's approved for adults with relapsed and refractory Hodgkin lymphoma, and they had to have prior treatment with brentuximab vedotin and an autologous stem cell transplantation, and the EMA approval is very similar. Pembrolizumab is a humanized IgG4 anti-PD-1 antibody, and it's FDA approved for adults with relapsed and refractory Hodgkin lymphoma, irrespective of the prior treatment, and I will come back to this later, and also approved for pediatric patients who had received more than 2 lines of therapy, and it's additionally approved by the FDA for relapsed primary mediastinal B-cell lymphoma after more than 2 lines of treatment. The EMA approval for pembrolizumab includes adult patients with relapsed refractory Hodgkin lymphoma after brentuximab vedotin or autologous stem cell transplantation in eligible patients. During the following slides, I just want to highlight the key data of these 2 agents and start with the more broadly used indication of relapsed and refractory Hodgkin lymphoma. And this is summarizing the pivotal phase 2 nivolumab data. And as you can see by the waterfall plot, there's really high efficacy in this setting, with virtually all patients experiencing a reduction of tumor burden, irrespective of the prior treatment. So this is color-coded whether patients were brentuximab vedotin naive, whether they had received prior transplantation, or whether they had received brentuximab and transplantation. And the objective response rate in this setting is around 70% with a CR rate of 16%. Despite the rather low CR rate, this patient group experiences a very favorable progression-free survival, which in the median is around 15 months. And this translates in a favorable overall survival at 1 year of around 90%. Similar data have been observed with pembrolizumab in this setting. And again, this is the pivotal phase 2 trial with a more prolonged follow-up. And as you can see on the left panel, we have, again, 3 cohorts. And the progression-free survival in those 3 cohorts is very similar, again, irrespective of the prior treatment. And the 20-month progression-free survival for all patients, color-coded in red, is around 30%. For pembrolizumab, the objective response rate, again, 70%, the CR rate a bit higher, around 30%, median progression-free survival similar to nivolumab, and the 3-year overall survival, again, very favorable in the range of 86%. So when we have a look at what patients might benefit exceptionally, we see that the progression-free survival is very much improved in patients who achieve a CR with pembrolizumab compared to the patients who only achieve a PR. And this is again data for pembrolizumab in the setting, and this is a very recent phase 3 trial presented at ASCO this year, who compared patients who were either ineligible for autologous stem cell transplantation or experienced relapse after autologous stem cell transplantation, and randomized them 1-to-1 to receive treatment with brentuximab vedotin, which is the approved agent in the setting, and the experimental treatment with pembrolizumab. And as you can see, color-coded in light green, the pembrolizumab treatment is more effective in terms of progression-free survival, and I think it's fair to say this is something many of us had expected. But when looking at the response rates, or the objective response rate and also the CR rate are also comparable between pembrolizumab and brentuximab vedotin, as is the safety in the setting. So there is several data points which are in favor of the checkpoint inhibitor, and this led to the approval of the pembrolizumab treatment for relapsed refractory Hodgkin lymphoma, irrespective of prior therapies, just recently in October this year, and the EMA submission by the company is pending at the moment. In terms of practical issues, I think most people, most colleagues who treat those patients know that they at one point usually experience treatment, experience progression. And this is something which was also looked at into the pivotal trials. And this is basically an analysis of the nivolumab trial, where they had a look at 130 patients who received the checkpoint inhibitor after they had radiologically confirmed progressive disease. And what we can see is that approximately half of these patients are able to achieve a disease stabilization and sometimes even regression, and that the time to next treatment is rather long, with more than 20 months. And this translates favorable to a 2-year overall survival with treatment beyond progression of 90%. And again, the patients who benefit most are those patients who have a best overall response of CR or PR. And so it's especially worthwhile to continue treatment beyond progression in this subgroup of patients. The other end of the continuum is patients who have an optimal response, so will achieve an early CR and a sustained CR. And again, in the pivotal trials, it was possible to take those patients off the checkpoint inhibitor after 1 or 2 years, depending on the trial, of sustained complete remission. And what was seen is that these remissions are sustained even without the checkpoint inhibitor and even without consolidative transplant. And this is also reflected by the more favorable progression-free survival and overall survival in this setting. And of note, retreatment in this setting is effective. So if a patient develops relapse or progressive disease after discontinuing a checkpoint inhibitor in the setting of relapsed Hodgkin lymphoma, the objective response rate and CR rate, at least with pembrolizumab, is similar to the initial treatment. So this is definitely something to keep in mind when taking a patient off this treatment, either due to toxicity or due to achieving a sustained CR. And what we have been focusing on, or we and many colleagues have been focusing on, is trying to understand why does anti-PD-1 treatment work so well in Hodgkin lymphoma. And I try to summarize some of the mechanisms of immune evasion and anti-PD-1 treatment in Hodgkin's lymphoma in this rather busy slide. And I think it's fair to say that immune evasion by the Hodgkin stomach cells is driven by PD-L1 expression, which is either genetic due to amplification, or induced by EBV infection. And this PD-L1 dependence is not limited to the malignant cells, but also induced by the tumor microenvironment, which is basically formed or shaped by tumor-associated macrophages, which are largely PD-L1 positive in the setting of Hodgkin lymphoma. And the Hodgkin lymphoma cells also have different mechanisms of immune escape, for example, by beta-2M mutations, which lead to a decreased MHC1 expression. The microenvironment is additionally skewed towards PD-1 positive T helper cells, and the population of LAG3 positive TR1 cells is abundant in Hodgkin lymphoma, and especially in the setting of MHC2 negative Hodgkin lymphoma, and increasingly understood as a key player for the rather low response rates to anti-PD-1 treatment in this subgroup of Hodgkin lymphoma patients. In addition to all those features, which are largely indicative of adoptive immunity, there's also a crucial role for innate anti-tumor immunity, which is reflected by the presence of PD-1 positive NK cells, who have been recently identified as a marker or key player in the efficacy of anti-PD-1 treatment. And this role of innate anti-tumor immunity is something we also observed in our own biopsies and recently published study, where we had a look at biopsies taken only days after the first nivolumab dose, where we saw histologic remissions, so disappearance of Hodgkin lymphoma cells without evidence of cytotoxic T cell responses, but rather a reduction of tumor-associated macrophages and the TR1 subtype. And I think taken together, it's fair to say that Hodgkin lymphoma is a unique disease in the setting of PD-L1, PD-1, and therefore might be serving as a model entity when further developing such treatments in the lymphoid setting. One issue to keep in mind in terms of practical approaching such treatment in patients is the toxicities of anti-PD-1 agents. They are so popular because they are usually well tolerated, but it's important to keep in mind that they might cause severe autoimmune mediated toxicities, which might be fatal if they affect vital organs such as heart, lung, or liver. And they develop over the time of treatment, usually within the first 12 to 16 weeks, and require really a vigilant physician and good anamnesis, clinical examination, and also laboratory sampling of these patients. And again, looking at toxicities, we see that the CTLA-4 treatment, and I will get back to this later, seems to be more toxic than the anti-PD-1 or PD-L1 treatment, especially when looking at grade 3 to 4 immune-related adverse events, who are seen in up to 10% of patients treated with CTLA-4 antibodies, but only in the range of 1 and 2% with anti-PD-1 treatment. Regarding toxicity in the setting of hematologic diseases, obviously the issue of allogeneic stem cell transplantation emerges, and this is one of the earlier studies summarizing the patients who received nivolumab who received allogeneic transplantation after nivolumab in the pivotal trials. And while the efficacy data are encouraging, so the 6-month overall and progression-free survival are in the range of 85%, and only 77% of patients experienced relapse disease, the incidence of GVHD, and especially grade 3-4 GVHD of around 25% remains challenging. And on the lower part of this slide, you see basically a comparison of the nivolumab-based data, which is highlighted by the box, and some historic data sets of the EBMT. And while the treatment-related mortality at 100 days after transplant seems comparable after nivolumab, the incidence of grade 3 and 4 GVHD appears higher, while the overall incidence of GVHD is comparable. I mean, these are small numbers and usually based on retrospective registry data, but it's important to keep in mind when considering allotransplant after prior nivolumab treatment. This is one slide looking at pembrolizumab in the setting of a relapsed and refractory primary mediastinal B-cell lymphoma. It's summarizing the Keynote 013, which was the phase 1 trial, and the Keynote 170, which was the phase 2 trial, and was published in JCO last year. And as you can see, the objective response rate is around 45%. CRs are observed in up to 30% of patients, and the median progression-free survival, depending on the trial, is up to 10 months. The 1-year overall survival is around 60%, and in contrast to Hodgkin lymphoma, there seems to be an association between PD-L1 expression measured by H-score and favorable overall survival with pembrolizumab. So there is a biomarker which is derived from the setting of solid tumors mostly, which seems to be applicable in these patients. With that, I would like to move forward to emerging indications and just highlight the very active trial landscape. And I think this is something every one of us is experiencing in daily practice, where we see that the key players such as pembrolizumab and nivolumab are increasingly getting company by other checkpoint inhibitors and are increasingly investigated in trials, and they are especially investigated in combination therapy, such as immuno-oncology combination with targeted therapy, combination with chemotherapy, and also radiotherapy. And I think this is really the way forward, because the single agent activity was measured early on in phase 1 and 2 trials and was rather discouraging in some hematologic entities, and I will get back to this later. And what we see is that if we try to have rational combination of checkpoint inhibitors, there is increased effectivity also in hematologic diseases. And this is one of the phase 1b basket trials in relapsed refractory hematologic malignancies. And summarizing the efficacy, I think it's fair to say that there is some activity as a single agent in DLBCL, in follicular lymphoma and PTCL, but no relevant activity in other B-cell non-Hodgkin lymphomas and multiple myeloma. The following, again, very busy slide, and I apologize, is summarizing the currently available data. And it's fair to say in AML at least that there's increasingly data for combination of chemotherapy or hypomethylating agents with immune checkpoint inhibitors, and there is some activity with objective response rates in up to 40% and some sustained remissions in patients who are heavily pretreated. In the setting of acute lymphoblastic leukemia, pembrolizumab was ineffective as a consolidative treatment in MRD positive disease, but the combination with blinatumomab seems to be effective both with pembrolizumab and nivolumab, and the objective response rates are rather encouraging and would provide a chemotherapy option for those patients. In multiple myeloma, I think immune checkpoint inhibitors are really not effective. This was also confirmed by a phase 2 trial, and the phase 3 trials investigating checkpoint inhibitors together with IMiDs had to be stopped due to toxicity. In other lymphoid diseases such as DLBCL, the monotherapy efficacy is very modest, but very recently there was a trial published regarding pembrolizumab and R-CHOP which showed that the CR rate of 70% led to a 2-year progression-free survival of 83%, and this is something the investigators are looking into further. And in CLL, monotherapy again is inactive, but in the setting of Richter's transformation, pembrolizumab is effective and increasingly investigated in various phase 2 trials for this challenging disease. PTCL is an outlier. I mean, it's a very heterogeneous disease, and NK T-cell lymphoma is one of the entities, despite Hodgkin lymphoma, which is really an entity where monotherapy seems to be effective and is increasingly investigated as well. And last but not least, the setting of post-allo SCT relapse of hematologic diseases. There was a paper in the New England Journal in 2016 which showed that ipilimumab at a rather high dose is effective also in myeloid diseases, and more recently a lower dose of nivolumab was reported to be effective in lymphoid and myeloid diseases with relapse after allogeneic transplantation. And again, Luca Vago summarizes this excellently in his talk, which is available on the EHA platform. So how do we move this forward? And this is an idea which is elegantly discussed by Peter Brossart in his talk, which is available on the platform, and which basically promotes the idea that there is a certain activity of the immune checkpoint inhibitors by themselves, color-coded in blue, which might be improved if we try to figure out the optimal synergistic combinations and ultimately lead to survival improvements in our patients. And I just briefly want to highlight 2 examples before we get into the discussion. One thing we did in Hodgkin lymphoma is to move the anti-PD-1 antibody in first-line treatment. The first-line treatment of Hodgkin lymphoma obviously is very effective, but rather toxic, and we wanted to develop a treatment which is tolerable and at least as effective as current standards, and therefore did the phase 2 NIVAL trial where we compared a fully concomitant treatment with 4 cycles nivo-AVD to a sequential treatment with 4 infusions of nivolumab, followed by nivo-AVD, followed by consolidative radiotherapy in both groups. The primary analysis was recently published, and we saw very high CR rates already at the interim restaging, but also at the final restaging, and the very early high CR rate of more than 50% in treatment-naive patients after only 4 infusions of nivolumab was something we looked into more detail, because these patients really experienced a dramatic decrease of metabolic tumor volume and also, as previously mentioned, early histologic remission. So in summary, this is a feasible approach. It's delivering excellent 1-year progression-free and overall survival. And this is something we at least want to move forward. And therefore, we are in preparation of the soon-to-start INDI trial, which is might be a model for an individualized immunotherapy where we administer an anti-PD-1 antibody, in this case tislelizumab, for 2 infusions, and then stratify patients based on their response. And patients who have an optimal response and achieve a PET-negative remission will continue monotherapy, while PET-positive patients are escalated to a chemoimmunotherapy. And this is something which might open a window for an effective treatment also for older patients who are not really suitable for the sometimes very intense chemotherapies of hematologic malignancies. Another example is overcoming resistance. So if we treat with current standards, there's often the development of resistance leading to persisting disease or relapse disease. And this is especially challenging after allogeneic transplantation. And as discussed by Vago, the upregulation of T-cell inhibitor ligands is one of the mechanisms of AML resistance after transplant. And as already touched on, there is this paper on ipilimumab after allogeneic transplantation, and a very illustrative case of a patient who achieved a CR and who experienced a very early infiltration of CD8 positive T cells into the tumor after just 1 dose of ipilimumab, leading to apoptosis of the malignant cells and ultimately a sustained response. And I think this is just a very, very nice example of how we might be using checkpoint inhibition more rationally and try to build on the treatment principles we have in hematology. Another example, and again, coming back to my field of expertise, which is Hodgkin's lymphoma, we had our phase 2 trial on anti-CD30 CARs recently published in the JCO. And while the response rate and survival rates are encouraging, the progression-free survival is rather short at 1 year with 36%. And this might be due to a disease inherent mechanism where the PD-1 positive CAR T cells are inhibited by the PD-ligand-1 positive malignant cells and also macrophages in the tumor microenvironment. And this really poses the question whether anti-PD-1 treatment or genetic engineering of the CAR T cells to delete the PD-1 receptor might be effective to overcome resistance and ultimately improve disease control with CAR T cell approaches, taking into account the tumor microenvironment. With that, I am slightly over time and want to summarize that anti-PD-1 antibodies are effective and approved in the setting of relapsed and refractory Hodgkin lymphoma and primary mediastinal B-cell lymphoma. There is single-agent activity also in other entities such as NK-TCL and Richter's transformation. And there is encouraging data for combination treatments in ALL, AML, and DLBCL. And while the combination with CTLA-4 inhibitors yields higher toxicity, it sometimes seems to improve the objective response rates. And compared to solid tumors, which have PD-L1 expression and TMB, for example, as potential biomarkers, this does only partly apply in hematological malignancies. And I think we are still at the beginning of fully understanding the hematologic diseases and to investigate why some respond to checkpoint inhibition, others do not, and how we might leverage this therapeutically. In Hodgkin lymphoma, we are building on the feasibility and the efficacy of the shown phase 2 trials, and there's also a large phase 3 trial going on in the United States where they compare brentuximab-based first-line treatment to a nivolumab-based first-line treatment. And there's numerous other ongoing trials focusing on synergistic combinations. In terms of perspective and maybe leading to the discussion, I think it's crucial to understand the disease biology and microenvironment composition, ideally at a spatially resolved single cell level, which is crucial to develop rational immunotherapies. And an additional approach, which is really excellently summarized by Peter Brossart, is to target other immune checkpoints, such as LAG3, TIGIT, OX40, which might be able to mitigate the anti-PD-1 resistance and increase the efficacy of checkpoint inhibition also in other hematologic entities. We should try to use this treatment rationally, ideally biomarker driven, and to improve efficacy of other therapeutic backbones, such as transplant or CAR T-cell treatment. And I think the favorable safety profile of these drugs compared to the conventional chemotherapy is opening therapeutic windows for the increasing proportion of older or sick patients presenting with hematologic diseases. And with that, I would like to thank you very much for the attention at this late hours, and I really look forward to questions and the discussion.
Okay, thank you, Paul, so much for this extensive presentation. So I would like to continue to share. I will open the discussion, but before we do that, I would like to ask the other on-demand speakers, Peter and Luca Vago, Peter Brossart and Luca Vaga, to summarize their on-demand lectures. And I first would like to give the word to Peter Brossart. He is the director and head of the Department of Oncology and Hematology in Bonn. And he is focusing a lot of checkpoint inhibitions from another point of view. So please, Peter, could you summarize your lecture?
So checkpoint inhibitors are negative regulators of T-cell activation that are induced upon the engagement of T-cell receptors, and they function as a negative feedback mechanism. And there are two molecules that are in the main focus now in the treatment of malignant diseases. So it's CTLA-4 and the PD-1, PD-L1 axis in tumors. So CTLA-4 primarily regulates T-cell activity and priming in the secondary lymphoid organs, but it can also activate T-cells in the peripheral tissues. And it can attenuate the T-cell receptor activation through competition with a binding to CD28, which is a costimulatory molecule that interacts with the B7 molecules. But CTLA-4 has a higher affinity to these molecules. And CTLA-4 also recruits phosphatases that can dephosphorylate the T-cell receptor and the signaling via the CD28. So ipilimumab or other blocking molecules, they can reverse or inhibit this binding of CTLA-4 to B7. So by this improving the T-cell activation and priming, not only in the lymphoid organs, but also in the periphery. And it can also affect the function of regulatory T cells, as CTLA-4 is considerably expressed on these cells and is important for their function. And it was also shown, at least in mouse models, that CTLA-4 can deplete Tregs from the microenvironment of malignant tumor sites via the antigen-dependent cytotoxicity. So PD-1, PD-L1 is acting more in the periphery, and PD-1 binds to its ligands PD-L1 and PD-L2 that are expressed in many hematological cells, antigen-presenting cells, but it's also expressed on the tumor cells. And PD-L1, upon binding to its ligands, it's recruiting phosphatases that dephosphorylate molecules or dysphosphorylate the T-cell receptor, and also inhibits the signal via the CD28 molecules. So antibodies against PD-1 and PD-L1, they inhibit the negative co-stimulation provided by tumor cells when T cells enter the tumor microenvironment. And by doing this, it keeps the activation of the cells, and the cells are still able to lyse malignant cells. It's also important to say that the PD-1 has also probably intrinsic functions on some malignant cells, as shown for melanoma cells. It's also expressed on dendritic cells, on myeloid-derived suppressor cells. So there are many other cells involved in the action of these antibodies. So we probably don't really understand how it works, but this is just to simplify the possible action of these molecules.
Thank you so much, Peter. And I would like to refer to your on-demand lecture for details. And please, for the participants, you may ask questions now in the chat box of the present of your view. So I would like to give the word to Luca Vago. He is a physician scientist in Milano, in the where he is a group leader and mainly focusing on immunobiology and immunogenetics. And I would like to ask him to summarize his beautiful on-demand lecture. Luca.
Thank you. Thank you. So very briefly, my on-demand presentation is focused on explaining current knowledge on the mechanism by which hematological malignancies, and in particular acute myeloid leukemia, relapse after allogeneic transplantation. And I will provide 3 examples of known mechanisms of immune escape that end up in clinical relapse. The first one is HLA haplotype loss, which is a genetic mechanism, whereas the other 2 were more recently described by our group and John DiPerso's group at Washington University in St. Louis. And these are epigenetic mechanisms relying either on the downregulation of HLA class II molecule or on the upregulation of multiple T-cell inhibitory ligands. And probably the most relevant focus of a presentation that you can find on demand is trying to explain how recognizing this mechanism of relapse can prompt different type of therapies. So for HLA haplotype loss, we will not use donor lymphocyte infusion. We might use a second transplantation from an alternative donor, but of course we can also use non-HLA restricted immunotherapy such as CAR T-cell or bispecific antibodies. Instead, for downregulation of HLA class II molecule, we can leverage on induction of interferon gamma release, either by administration of this cytokine, which is however still toxic, or by inducing a mild GVHD, or we can leverage on epigenetic drugs, in particular on EZH2 inhibitors. And of course, for the upregulation of T-cell inhibitory ligands, we just heard on the promise of immune checkpoint blockade.
Okay, Luca, thank you so far. And I would like to open the general discussion now. And please, participants, ask your questions, but maybe I may start 2 questions to all of you. In this emerging field of all kinds of checkpoint inhibitors and a lot of several mode of actions, how can we now identify those most promising drugs, or which combinations are the most promising, which are ready to go into clinical trials? Peter, can you comment on that? Which are the most promising combinations based on the mode of action?
Well, we have already 2 very effective molecules that or targets that can be blocked, and such CTLA-4 and PD-L1. And there are several other checkpoint molecules that have been recognized in the last years, such as TIGIT or VISTA and so on, LAG-3, for example. And we know that when you block, for example, PD-L1 or CTLA-4 on T cells, then they start to upregulate other checkpoint molecules such as TIM3 or LAG-3. So it makes sense to combine PD-L1 with one of these antibodies. And there are already some clinical data that show that even in patients that progress to inhibition of using PD-1 or PD-L1 antibodies, when you use LAG-3, that's, for example, in head and neck cancers or melanomas, then you start to see responses again.
Do you think then the application of induction of resistance mechanisms might enable us to combine TIM3 as in a later stage, or the anti-EAT signaling, the anti-CD47, for instance, such kind of issues in a serial assessment of how can you think to combine them?
Yeah, it's a difficult question. I mean, the immune system usually works in sequence, so it's not like every molecule is acting at the same time. So it makes sense to not only to combine, but may sequential use different antibodies. So we called it, you need some kinds of, like in allogeneic transplantation and immunological conditioning of the tumor microenvironment, for example, by using cytotoxic drugs that induce immunogenic cell death, and then to add antibodies that stimulate priming, and like CTLA-4, it also expands the T cell repertoire, it lowers the threshold for T cell activation. So, and then when you have T cells, they have to go in the tumor microenvironment, and then you need antibodies like PD-1 or LEG-3, that keep these cells alive and provide keep their function alive.
And Paul, you mentioned clearly that you have some studies done in which you did after nivolumab, you had some biopsies in the lymph node, and it was amazing that mainly the tumor-associated macrophages or other suppressive elements were out of the tissue, and that the cytotoxic T cells were not relevant in that case. But I do not understand that at the end, the cytolytic activity towards tumor is not based on a tumor-associated macrophage. How can we explain these observations?
I think that's an excellent question, and we took the biopsies because the clinical observation was that Hodgkin lymphoma patients, they have resolution of symptoms and tumor masses within days after the first anti-PD-1 dose, and if you try to catch this and then take a biopsy under the microscope, you don't see Hodgkin Sternberg cells anymore, and by gene expression profiling, you see a clear drop in CD30 expression, for example, and you don't see a cytotoxic T cell signature in those biopsies. And when further looking, also at spatially resolved and whole slide imaging analysis, we see that especially the PD-L1 positive tumor-associated macrophages, so which are close to the Hodgkin-Sternberg cells, they are gone, and other macrophages which are not as clear PD-L1 positive and who are more in the stroma of these tumors, they are still persisting. And while at least in our study, which is a bit limited by the quality of the samples and also the methods we could apply, we basically had the observation that without any sign of a cytotoxic, at least CD8 positive cytotoxic reaction and no sign of T cell receptor expansion, we see this vanishing of the Hodgkin-Sternberg cells, and we seem to observe some withdrawal of survival signal maybe by disrupting the PD-1, PD-L1 niche in this setting.
If I now can continue on the work of Luca regarding mainly the HLA-DR, which is either genomically regulated or by a decrease in the expression by all kind of pathways. And you alluded in your talk about the use of hypermethylating agents into the pathways of HLA-DR. Can you comment on that, how HMA maybe can be translated also to lymphoid diseases, as Peter or Paul in their lymphoma studies?
Yes. Well, at least from our immunological perspective, we observed that HMAs can have different activities. And one for sure is related to the expression of histocompatibility molecule. There is a well-recognized role in inducing expression not only of HLA class 1 and class 2, but also in prompting the expression of some tumor antigen. But also checkpoint molecules are actually potently induced, and in particular PD-L1 is induced by hypomethylating agents. So for instance, for those diseases, the relapse with the upregulation of immune checkpoint, using hypomethylating agents alone will probably actually not be effective because it will actually increase the expression of checkpoint. But if we combine it with checkpoint blockade, we can actually synergize and potentiate the effect of checkpoint blockade.
And Paul, you do a lot of studies then combining all approaches with conventional therapies, etc. And most hematologists has also experience with decitabine and azacitidine. Why not then in lymphoma, in related to the Luca's concept?
Yeah, excellent. I think it's rather historic actually, because we rely on the treatment modalities we are familiar with and which are effective in a certain setting. But from a mechanistic point of view, you're completely right. We should try such combinations also in lymphoid diseases. And there is preliminary data on a Chinese anti-PD-1 antibody and decitabine actually in Hodgkin's lymphoma, where they clearly showed that they could overcome resistance to the anti-PD-1 antibody alone, inducing durable responses and producing a higher CR rate than to anti-PD-1 monotherapy. And this was a very low dose of decitabine, and I think it's very promising to follow such approach, especially in heavily pretreated patients, and then to move this upfront further, as Peter also elucidated, to try to really sequence the whole therapies rationally to fully leverage their potential.
In line with that, a question from the audience: has lenalidomide ever been combined or used in a sequence of immune checkpoint inhibitors? So the question is whether or not immune modulatory drugs like Peter, you can comment on that maybe.
Well, lenalidomide has a plethora of different effects on the immune system. So we analyzed in healthy, but in multiple myeloma patients the effects, and it's really difficult, you know, to see. Sometimes it's more stimulatory, but it can also affect NK cells and so on. So it's not clear cut. And the clinical trials show that it's probably not a good idea to combine lenalidomide with checkpoint inhibitors, at least in myeloma patients.
Yeah. The studies were stopped.
It looked promising in the first phase 1-2 trials, but then it was stopped completely.
Yeah. And maybe together the question: why is it so successful in lymphoid malignancies, mainly then Hodgkin, and in the liquid leukemias or in CLL, even in CLL, the checkpoint inhibition is not yet there. What is your opinion on that? The microenvironment, it's an easy answer, but can you comment more?
Maybe I can start on the liquid malignancies and on AML. I think for us it was quite striking to see how different is the picture for AML in the setting of leukemia diagnosis or at relapse after stem cell transplantation. So I really think that a disease at time of diagnosis or relapse refractory just after chemotherapy is not so capable of inducing that type of inflammation and that reaction in the microenvironment that probably instead is so relevant in diseases like Hodgkin. I can say that there are data from Leo Lutznik in Baltimore saying that some of refractory patients with AML actually have already expression of this checkpoint. So for refractory diseases, for some of them, well identified by biomarker, it might be useful to start immune checkpoint even before transplantation. But really what is making the difference is the graft versus tumor effect and the inflammation that is driven by the donor-derived immune system.
Yeah. A final remark of Paul and Peter before we close the session.
Yeah, I mean, I think it's, you know, PD-L1 probably does not represent a escape mechanism for this kind of malignancies. And now we especially look for CML patients, and they express sometimes high levels of PD-L1, but inhibition doesn't play any role in these diseases. And sometimes, I mean, there's some evidence that these molecules, PD-1 and PD-L1 as well, they have some reverse signaling as well. So sometimes they may provide signals, you know, that are important for the cells. For example, it was shown for T-cell lymphomas that when you remove PD-1, you remove the inhibitory signals for the T cells, and then the T-cell lymphomas start to proliferate instead of disappearing. So it's difficult for each disease different.
Thank you so much. I think we have to stop. It was an elegant discussion with you guys, and I would like to thank you for participating in the SVG meeting today and for your kind discussions. Thank you so much. We move on to the final session of today. Thank you so much.
Bye-bye.
Bye.
Thank you.